Let me welcome everyone to today's Thursday research conference. We, as those of you who are regulars in the department know, we do this on an intermittent basis over the summer. We don't have talks every week like we do during the academic year, but when someone interesting is passing through, we make sure that everyone in the department benefits from their knowledge and wisdom. And today's actually a special kind of talk that we have in the department. Some of you know we have been starting up this new activity, initiative, whatever you want to call it, within the department called the Informatics Discovery Lab. The idea of being an effort to engage more with industry, disseminating our work, both our research, our education, things that we develop out into the real world, and working with companies and others to do that. And so today we have a visitor to the department most of the day, actually a couple visitors from GE Healthcare, one of whom is going to give a talk. Before I introduce him, though, let me just ask those of you who are here, if you didn't pick this up, is a survey. We're just trying to get some feedback from people who attend our conferences on what things you might want to hear about and other speakers we might invite and so forth. So then let me go ahead and introduce our speaker, Peter Kinhan, who's a general manager in the Integrated Care Group at GE, who is based in Seattle, though like many people, he spends time other places around the country and the world, and he has actually quite a resume, which I won't cut into his talk too much from going through. But right now he's a general manager in the healthcare IT division of GE, and he leads a business called Integrated Care that's focused on helping healthcare providers rethink and rewire their care delivery processes to excel under new healthcare delivery models that are taking shape in the United States, such as accountable care organizations. And he has a wealth of experience. He's been with GE for 8 years. He's worked for other companies, including consulting company Ernst & Young, and another health IT vendor, Eclipsys, which is now part of Allscripts. He has an MBA from, I won't try to pronounce the French name of the university, I'll just use its acronym, HEC, which is based in Paris, and he's done work in many other places around the world, in Europe and Middle East. So I will turn it over to him and have him enlighten us.
Thank you, Dr. Hirsch. All right, very good. So I've been with GE for about 8 years. My last role is focused around, my current role, I should say, is focused on something we call integrated care solutions. And for GE, integrated care solutions is our response to helping organizations with what I think is an incredibly disruptive time that's happening both in the U.S. and abroad right now. I mean, the payment models I think are on the cusp of being put on their head. And I think when you start to do that in a healthcare system, you're going to start to see real change. real change and some real challenges coming up. So I want to talk to you about what I'm seeing both in the U.S. and abroad around what organizations are struggling with, what problems they're trying to solve. I'm going to talk to you a little bit about how we are responding to it as a company, and just try to talk. I mean, if there's so much buzz and discussion about what accountable care organizations are in the market, I just want to at least kind of ground us on what I think are some of the most important things and foundations of that and how it's playing out in the market today. What I would love is if you guys would not be bashful, interrupt me with questions. I personally much prefer that than just kind of, I've got slides, I can jump around, but I would much prefer a discussion as we go. I think we got an hour, and I would be thrilled to engage in your questions. So don't be shy.
Let me just interrupt. Yeah. One thing, when people ask a question, if you could please hold down the microphone in front of you so that gets recorded on the tape too.
Sure. Very good. Okay, you can go to our website to get a lot of the overview, but basically GE is a large healthcare company, part of a larger GE company. We do about $17 billion, operate in many different countries, got about $1 billion in R&D. We have many different businesses. I represent really two of them. One is the healthcare IT side, and the other one is a group called Performance Solutions, which is our healthcare consulting division. But we have colleagues who work on medical devices, scanners. I think something like 60 to 70% of all equipment you see in a hospital we could potentially make or sell to you. So we're pretty big in that space, and to be frank, they help pay our salaries. It's a big part of our company. I heard a great quote. I was in D.C. There's a customer of ours there called MedStar, and he said, "Peter, you know what? Healthcare is going to transform at midnight. We just don't know what time it is now." Right? And I think it's such a critical thing for me. I take away, I mean, strategy is easy, right? Timing is hard. Strategy is easy, timing's hard. I mean, how many, the graveyard is filled with patient engagement companies who tried to get in too early, right? These innovators are trying to get in. Healthcare has been an industry that's been slow to change, but I believe we're starting to see a turning point, and the pressures are starting to really come to fruition. So I like this quote. And here's why I think we're at a turning point. The health system is starting to change the way they finance, the way they reimburse patients. And you're seeing this shift to more and more risk being passed from what's essentially been in the payers, whether it's CMS or commercial payers, down into the provider space. And there's three market vectors I want us to be thinking about. First of all, it's the ACO growth, right? Everybody's probably read the headlines, with Obamacare. You're seeing more and more of these ACOs popping up. I think the latest count is something like 400. I hear there's 700 applications pending for the next round. I go to the Brookings, Dartmouth learning sessions, and they just held their conference in D.C. a few weeks back. 3 years ago, everybody was there saying this is a load of crap. I think I can say that on the microphone. And they were fighting the rules. It wasn't fair. It was unimplementable. The year after that, they were saying they'd made some changes, and they were starting to get in and share learnings. And then this year, everybody was talking about how they get to the next wave. So it's not just a CMS ACO they're doing, but they're now doing that with Aetna. They're doing it with Cigna. They're doing it with other commercial providers, which means they're going beyond dipping their toes, and they're building more capabilities. And I think it's interesting to watch that. However, what I would posit is that the ACO growth is probably it's just one part of the transition. And I would look at things like Medicare Advantage, where you're seeing basically the full capitated rates being pushed down to providers in some of these scenarios, and look at Medicaid. Oregon's a great state. Look at how the state is managing the Medicaid populations. All of this forces healthcare organizations to think about when you're at risk for these populations, you can't deliver care the same way you've been doing it for the decades that's preceded us. It's not about volume. It's going to be about value. Okay? So we do some very basic math from a technology perspective. We think it's a multi-billion-dollar opportunity. And Citibank recently published a report. They think it's about a $10 to $17 billion opportunity. We're a commercial company. We want to return value to our shareholders. These kinds of things are important to us. At the end of the day, this is why you're seeing a lot of competition and investment going into this space. I won't go through this a lot, but has anybody read the Oliver Wyman report that's out there around this shift to value? It's a good read. It's available free on the internet. I think they've done a nice job there. They've got some partners there who are pretty well educated. They are really talking about this shift to volume and looking at the different payment models and how it's all about following the lives, following the covered lives, and they do a nice job of uncovering some of those trends. But you guys have seen graphs like that top right, I'm sure, in your informatics classes or other things. At the end of the day, it's a battle of scarce resources, right? Health systems need to focus their resources where they want to improve quality and reduce cost on the patients that most need it or that will most engage in it or be most activated by it. We don't have resources to spread it across the whole populations, right? So that's why analytics, informatics, et cetera, have such an important role to play in this. Okay, so I think I'm my last page on the market, but I'm an economics guy, and I think it's so important to think about what do the economics look like around. Let's take the ACO contracts as an example. So imagine a Medicare ACO with 100,000 lives. Let's take a rough ballpark of average spend per patient of, say, $12.50. So you got about a $1.2 billion worth of spend for 100,000 lives. Okay? These organizations, what they're saying with these ACO contracts is we commit, or our goal is to reduce the cost of those 100,000 patients. I'm going to reduce the rate of growth around those 100,000 patients, right? While maintaining or improving certain quality metrics, all right? So by reducing that $1.2 billion, you're essentially freeing up between, if you take a 2% savings to, say, a 5% savings, you're freeing up or you're reducing about $25 million to $63 million in quote-unquote savings, okay? Of which they're going to share a percentage with the payer. A lot of these ACO contracts with CMS are 50-50 share. Some of them in the earlier days were a little bit different. But just for simplicity, they basically get a payback of 12 to 30 million on the CMS lives, which correlates to about $10 to $26 per member per month. So per 100 of those 100,000 population. And again, I don't know what you guys are. If this may be just real basics, but the industry is changing the way they start to talk about these things, right? Per member per month was not something that hospitals or health systems talked about much. That's a payer thing. That was for the payers, right? Now, in the discussions I have day in, day out with customers, they're all talking about how do what's the right PM spend? How many care managers do I hire per populations? What kinds of informatics do I need in order to identify those high-risk populations, et cetera, et cetera. So essentially, imagine your advocate in Chicago who's done a nice job of publishing their learnings in this space. They took on 100,000 or 150,000 CMS lives, about another 300,000 Blue Cross lives, and they purport to get about 2% savings across that. So what did they do with the money? I don't know. What would you guys do if you were going after a $1.2 billion spend? What would you do? Any ideas?
Well, they managed care to a certain set of metrics. They started with about 8, and then they went to about 160, 165, and now they're back down to about 140.
Yeah.
Most of the money goes back to where it should for physicians.
Yeah. So you put incentives in place, you get your physicians aligned, and you get some clear quality metrics. What else would you do? hire some good students in informatics, maybe? Yeah?
Well, maybe we'll get to this later. The question is, how does the insurance company
The one at the bottom, yeah.
how does the insurance company share those savings with the medical providers? And I'm not sure what sort of formulas or plans they have to be able to do that. Because you've got to incent the provider to decrease the level of services.
Yeah, and I think that's kind of plays on the earlier point. So let's imagine in this way it was simple. So Advocate or these other organizations, they get 50% of those savings kind of paid back at the end of the year in a check. It's then up to these organizations to think about how they share those incentives with the participating physicians and other groups. Good point. What else? What else? Any other ideas of what you would do to go after that?
A little bit this morning, but you've got to keep turning the crank, right? So you have to invest in the system and the tools and the technologies and the training and the people in order to keep doing that, right? Because it's not a stable target; it's a moving target, and you're going to be expected to continue those cost savings for several years and increase them. So how do you do that? You need to invest in the way to do that.
That's right.
In addition to incentivizing people by sharing the savings with them. Those that are generating it.
That's right. That's right.
And the better models like Advocate, Geisinger, Group Health Cooperative, Intermountain, they look at the low-hanging fruit with the self-insured groups and meet with them in a dynamic way to make sure that they know what areas they want to kind of control cost, and then they have some partnership arrangement to do that. Different technologies are employed, but it completely involves the clinicians, and the metrics may be reducing surgical site infections, it may be any number of things, but as Aaron said, each year it's dynamic, so they get more progressive in it.
Yeah, I agree. I'm gonna come back to that idea of dynamic. I think it's a really important point. Any other comments on what people would do? What you'd spend your money on? Yeah.
Just to follow up on what Aaron said, I think a lot of the efforts are going into data warehousing.
Yeah.
How do we actually build the databases so we can take and do better analysis, see where our care gaps are and how we fill them?
Yeah. Yeah. We're seeing a tremendous increase in spending in that space, and some really interesting startup technologies coming out of there.
Could you comment on the new? Well, I think it's not that new, but the notion of data binding at the user end for these facilities are using, because that's a concept where I'm seeing more about, but in your space, I'm sure you work with it daily.
Do you mean in terms of some of the late binding technologies that are coming through with the?
Exactly.
Yeah. Yeah, I can't. I'm not. That's technically I would get out of my depth a little bit when I start to talk about these things. But what we're seeing is a couple of things. There's a couple of interesting firms. One is we have a joint venture with Microsoft, something we call Caradigm, where we're focused on some technology in this space. I also follow groups like, if you've seen the Explorers group coming out of Cleveland Clinic, or Healthcare Catalyst, I think is a really interesting group coming out of Salt Lake. One thing that we're finding is that the data warehouses of the past have struggled in some ways in that they create these, they go through tremendous long cycles of designing the perfect data model. And what happens is they kind of never get to the end state of how do we get the value from that. And so what we're seeing is more flat data structures where you bring the data in its raw form, kind of with all the impurities that exist. And then what you do is you add value, enhance that through different parsing technologies, through different data sets that you combine. But you kind of let the informatics teams play with that in its raw fashion and then refine it as you go. So you might, when you find out that really important nugget of information, you might then move to a more traditional cube or other kinds of structures but you do that for performance, but you keep that raw data and its impurities because there's a lot of value in that. It actually is, I bet you guys see that in some of your research with EHR. I mean, sometimes if you clean up all that data that may be problems in the way the EHR is capturing the data, you kind of never correct for it down the road. So we're seeing a lot of that. I don't know if that answers your question, but yeah, okay. Good. So anyways, so the point is, this is what people are going after. The economics of investment revolve around this when you're talking about this integrated care or more accountable care space. But look at the difference between the dual eligibles, the Medicare, Medicaid kind of populations, which are kind of a proxy for quite high-risk populations, and say a more commercial population. I mean, just look at the difference in terms of the money that can be freed up. And then if you start to think about, well, the strategy I deploy for I needed something which is scalable for my dual eligibles, but as well as my broader populations, because as somebody was saying earlier, this needs to be dynamic. This is a learning system, right? What you may be focusing on your top high-risk patients today, in a couple of years' time, you'll be focusing on the wellness and a much broader set of populations. And so these economics become really, really important, right? If I'm a supplier into the market and I'm pricing my solution, and if I'm going into a dual eligible, I might think of a certain pricing structure, but that doesn't work when you get out into broader sets of populations. And so it's a real challenge that these organizations are going through. Okay? Payers have been living in this world for decades. Okay? All right. So let me just share some of the research that we've done internally at GE, and it's to come back and answer that question, what do you do about this change? What are organizations investing in terms of new capabilities? And first of all, we funded some of our own focus groups and research of ourselves, and there's a ton of stuff out there to leverage as well. And first of all, we started with the hypothesis that there's 3 pillars to responding to the shift from volume to value. The first pillar is, how do I manage the financial risk that's inherent in that new world? Okay? What systems, what capabilities do I need? The second one is, how do I coordinate the care with population health or care management systems that help me coordinate care across the continuum? And thirdly, how do I engage the patients in this new paradigm to drive more compliance around what is evidence-based care, but also more loyalty within the system? And what we said was, it's not just a simple install it and walk away or build it and walk away. These things need to evolve and have this kind of optimization curve to it. So what you might implement now needs to have an optimization piece which comes back and informs how those systems evolve. And then we went out, and as we started to talk to the market, we realized, wow, there's tremendous diversity. You talked about Intermountain and Geisinger and those kinds of firms. What about the hospital I was born in, New Hampshire? They've signed up to 3 ACO contracts. They got 2 small hospitals, an integrated physician practice, but they've never, ever thought about taking on risk other than basic pay for performance and fee for service. So they've gone out and signed up about 40,000 lives, put themselves at risk, and have no idea. I mean, they have some idea, but they don't really know how they're going to move the needle on that cost. Okay, and if you look at the numbers of, if you look at the people that are getting the press about signing up to these ACOs, has anybody asked themselves, how the hell do you do that with 12,000 lives here, 5,000 lives here? I mean, what we learn about risk is that risk is good against big sets of populations, not these little micro populations. So as a commentator, I struggle to see how that plays out. I think this kind of plays to a consolidation game at some point, which is, I'm not quite sure what the end state is. But I can tell you the end state is not the ACOs we read about in the papers today. The end state can't be, woohoo, I got 10,000 patients on an ACO contract and I hope to get 2% savings. That can't be the end state, right? So this has got to be a step towards something else. And that's why what we see is organizations dipping their toes. To be frank, the ACO contracts they sign up today, often there's no downside risk for 2 years. So what are they, it's okay that their contracting capabilities outpace their care delivery capabilities. But at some point, they will move into more mainstream or try to get to forerunners, or I think or I think something else will happen that they'll break out of this mode. Okay. Anybody see it differently than that? I'm kind of my own commentary, but challenge me if you think I'm off track. Yeah.
Not a challenge, but so you're saying the simple economics of it will entice people to it rather than forcing them to it. Is that what you're saying?
I think that's what they're trying to do. I think they're scared to death of the 90s when managed care broke the backs of the system, and they're scared to death of putting too much. I mean, simply put, the pioneering ACOs, kind of the names that some of we've thrown around. I think there's 18 or 20 of these organizations. They either never left the HMO days, or they had a health plan, or they're very sophisticated kind of organization, right? I think all of them might have had a health plan, if I'm correct. Yeah.
Where do you see? I'm thinking. The emails I get from our organization. Our 14,000 employee organization. That's actually self-insured.
Yeah.
Where do you see the role of self-insured organizations? And I don't know the details of whether there's some insurance that OHSU has if it exceeds a certain level or something like that. But where did those fit in? I know a lot of large corporations now are self-insured.
I think they play a real big role, actually. We see often with systems of equivalent size, their first step is often their first step is not an ACO. The first step is their own employee base, and that's where they start to build the muscle for some of these things. So we see that quite a bit, actually. But again, I don't think that's an end state. It's a learning process along the way. And I think these examples are just ways of enticing people into the system, because I think the CMS, they're scared to death that this is gonna break the system, right? They want this to be successful, in my opinion. Yeah.
Isn't the answer just merely at some point, like they did another reimbursement system, CMS, to just say that if you're not in some ACO, then your payments are less?
Oh, for sure. Totally. That is happening now. Yeah. 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 But I think in the world we're in now, there's still a little bit of that enticing, right? It's that carrot and stick kind of thing.
Do you know why Oregon is so far behind the curve in all of this? Because I understand there's only one pioneer ACO in the entire state, and it's somewhere out in the West. Would you have any other reason?
Well, yeah, I would say you guys are kind of advanced.
But aren't ACOs Medicare?
ACOs are Medicaid.
So then I don't understand how the
ACO is actually a term
waiver
that
applied.
even the commercial payers are picking up on as well.
Well, right. So I'm sure that Advocate considers themselves an ACO irrespective of whether or not they've contracted with Medicare. But I'm saying that I thought the CCOs, at least the waiver, was a Medicaid convention.
Right.
And ACOs were a Medicare convention.
That's right.
Then why
That's right.
would the CCOs have anything to do with Medicare? In other words, why would
But
Oregon be this far
I would argue the
behind?
capability is the same, the population is different. And the way it gets reimbursed just might be, I don't know the CCO details that well, but I would imagine it's a similar kind of construct. The commercial payers are taking the ACO, are taking what you see in CMS ACO, and they are applying some of the same terms with their own tweaks and local negotiations. So ACO is becoming more of a generic term. It's not just a CMS term anymore.
Employer-based coverage, you're going to see the ACOs get into that business. That's how they're going to sustain. Because you can't. I program manage an ACO in Texas, and you can't live on being a Medicare ACO.
Yeah,
it's nice.
I agree.
It's
you're preempting my slide. I couldn't agree more with you.
Sorry, but those you'll see them starting to take on risk through employers and managing the health of employees in the same way that they're trying to manage the health of beneficiaries.
I agree. And Medicare Advantage and Medicaid and other things.
And then you'll see other products and things coming out to do gap coverage.
Yeah.
Depending on where you are and where those ACOs fall into the healthcare or the health insurance exchanges, what's allowed. I mean, we're doing that in Texas right now. Texas is a little weird, but we're going to be able to offer primary care coverage through our ACO, an indemnity plan for catastrophic, and then we have.
Can I ask where you come from?
I live here in Oregon.
Okay.
But we have an ACO. We actually applied for a Pioneer and didn't get it. I think we got it in the second or third round. But it was Physicians ACO
Okay.
in Houston. And we also have another one that we were standing up called Southwest Houston ACO.
Okay. So what do you think of this physician-led ACO? There's a tremendous amount of... Sorry.
Oh, I'm sorry.
Okay.
I'll try to get closer. I came in late, so I'm sorry. You were.
There's a lot of things happening in the market with it. There's a tremendous amount of physician-led ACOs in quantity being published around ACOs. So no hospitals, and it's an interesting play.
They have physician-led. They have to
Well,
be 75% physician-owned.
But I mean, they have no hospital in their.
Right. Yeah, we're an indie, right? We're an indie, and it's harder for independents than it is for hospital-based ACOs, definitely, because they've got the bully pulpit. They've already, like OHSU, for instance, has Epic, right? And they offer Community Connect to other partners, and so there's value in that. But there's also value in the private ACOs as well, where you talk about smaller populations.
Yeah.
Because those smaller populations don't necessarily fit in well to a population health model. You might get more traction with them in dealing with a smaller population or special communities. See a lot of that as well. A lot of ACOs around Chinese healthcare communities in the Bay Area.
Okay, interesting. I think also in some ways those physician practices have the nimbleness and they don't have to keep the beds full. So in some ways they can. We see quite a bit of innovation happening in that space because they can move quickly. Whereas some of these larger systems, they get in these big kind of conference rooms and they have committees to make decisions. And at one end of the table, you've got the hospital CEO who's saying, "How do I mean, reducing ED meds is great, but I'm still getting, I've got a bunch of overhead I got to pay." So.
Yeah, it's actually funny. There's data and examples of hospitals struggling because their readmit rates have gone down because their quality's gone up.
Exactly. I was talking to somebody the other day. Says, "I don't want to be best in class on readmits. I want to be just in the middle where it kind of makes sense." So how can your analytic help me stay just in the middle?
And like you said, it's a dynamic system, so
Yeah.
that incentive might change, in 12, 18 months.
Right. Interesting. Thank you. Okay, so we understood, tried to pick out what are people really focusing on from an unmet need? What are the real problems? And we landed on 3 themes. So this is, and I was asking the question, what would you guys do? What would you spend your money on if you were looking to move from volume to value? This is what we found from our market research that the market was spending money on. And sorry for my coarse language. They're not just spending money on it, they're rethinking their processes. It's more than just that. But the first thing is they want to understand essentially the risk that they're signing up for, right? So we're coining that population and contract analytics because we think it's about the populations, but it's also how does it impact the contract that they have with the payer, whether it's CMS or another payer. And in that bucket, you've also got how do I help predict what the value of a certain intervention could be, or how do I help predict what the right cohort of population will react to certain care intervention programs, et cetera. So you've got this is for an informatics class. I mean, this is ripe with decades worth of research and work. I mean, we see the big guys going after this, if you're Optum or whether you're Verisk or some of or Aetna's group or others. These guys are coming at it. They're saying, "Hey, we've got hundreds of actuarial informatics people on staff. We know this stuff, right?" Then you've got the small firms in San Francisco who are the data guys who just know how to crack data. And then you've got this kind of mix of people who maybe come out of the disease management space and trying to bring kind of predictive analytics to it. I think it's an incredibly exciting time. And then you've got, and not to overlook, you've got some fantastic faculties at different organizations, like this one, and others who are doing tremendous amount of work in this space. And so I think it's just ripe with innovation. The bet that we're making from GE is that, first of all, I struggle to see how the payer-based solutions get real traction. Would you guys want to be getting the data from the same person you negotiate with? I don't get that. All right, great products. I mean, I value. I think they have a tremendous amount of capability, but I don't understand how that plays out in the long run. Right? We're a provider-based company. We don't sell any products to payers. So I live in that world, and that's our client base. But they're scared of that. They see that as that information asymmetry as being very threatening to them. So we think we have this is an area we're investing in. We have data that we can leverage, which is claims data, but also clinical data. I mean, man, we've been putting in all these EHR systems. If we try and base all of our predictive analytics around claims data, what the hell do we put all that EHR stuff in for, right? So we're focused on that. We think there's a good opportunity, and there'll probably be roles for everybody. But I can tell you, this is definitely one area where organizations are spending money. The second thing, and it goes back to your point in that green area, is around how do you manage the financial risk, and that's everything from eligibility and benefits, referrals, network optimization, payment adjudication, all those things that payers have been doing now suddenly become a provider role. And that's more complicated, or at least it's different than just coding and billing. So.
I was going to say, though, it does start to offer direct care opportunities in a big way once they have that data. Basically, that's one of the products that we offer is the ability to subscribe to your care on a monthly basis.
Uh-huh.
So it's like concierge, but it's not with all the bells and whistles.
Okay. What is it? When you say subscribe to your care, what do you mean by that?
Well, in this particular model, it's a membership organization, nonprofit, that the providers and the patients join, and the nonprofit acts as the fiduciary intermediary handling the transactions. But the relationship is between the patient and the doctor, and they're paying $40 a month to have their primary care covered.
Okay.
Go once a month, or as many visits as are allowed under whatever contract you have. But those types of things as well. I mean, and then allowing those types of models to be accepted as qualified health care coverage under the Affordable Care Act too is another piece as well that we're working on.
Yeah. Okay, and then the third area we think is a really big area around, we're kind of calling that care management and patient engagement. I should stop and say, our research said, don't think about these things, connected. Like, don't think about them in silos. In some ways, healthcare has been too siloed for too long. So they said, patient engagement is more effective if you think about it as part of your broader care management or population health capability, as opposed to being something kind of off in a corner and kind of a science project, to be honest. Okay. Any comments? You think I'm missing anything here? No? Okay. I think I just got a couple more pages, and then I'd love to get some more discussion. So the other thing is we think about is, at the end of the day, we're doing this to solve for a problem. And kind of my consulting background, I like to think of things in terms of, what are we trying to drive for an outcome? What are the levers that we're going to try and pull on to get there? And if you think about the outcomes on the right, again, metrics that payers have been thinking about for a while will become more and more what providers are talking about. So, understanding what your population's hospital days per 1,000, ED admits, readmissions, compliance to care on a number of factors. Essentially, if you guys probably follow Brent James down at Intermountain and some of his work, I love the work that he's done around how to reduce unwarranted variation and some of that space. And I think this gives it a real home, right? I think sometimes where Dr. James' theories struggle to get into reality is that it wasn't always financially incented to reduce clinical variation. And I think this gives Dr. James a fantastic home for his theories and his methodologies that he purports. So that's the first piece. And this is where a lot of the low-hanging fruit is, where people are going after. Simple thing: keep people out of the ED. Right? That's where these early things is you can get 2 to 5% fairly easily in these early years by doing some simple things. That won't work, however, in year 3 or 4 or 5. Okay? And do that with a quality mindset and quality metrics. I think often get the question, and you guys probably study this a little bit too, is what's the difference between now and the HMO days? And I think there's a couple differences. First of all, I think we're putting quality much more at the forefront of this than we did back in the 90s. And secondly, I think we have better data to measure it. I hope we do, at least. Right? And I think this will be a key piece to the puzzle. And the third element is will become more and more of an issue. It's how do I do that in a cost-effective way? So how do I set up an organization that is efficient and provides a return on investment, to be frank? Right? I can go and hire 100 care managers to go after that population of 10,000, but can I do the same with 10 care managers? Right? Those are the kinds of things, and how do I build an operating system? Yeah? You disagree?
Squeezing the screws tighter and tighter.
Yeah. I don't see any other way around it, right? Yep.
One question is where does the physician fit in here in terms of guideline-based care? Somebody comes in and they want a whole-body MRI. There's no incentive right now for the physician to say, oh, okay, we'll order the whole-body MRI. Where does that come in? Guiding the physician as to what's appropriate, what's not appropriate.
Well, for me, it's kind of part and parcel of some of the levers that you drive in those first two ones. I mean, you do that, you drive that physician alignment around evidence to reduce unnecessary variation, but also to improve quality. For me, the physician is at the heart of all of this stuff. It really is. Yep.
But I think this speaks to the importance of process.
Yeah.
Like the people who've been able to effectively implement guideline care work from a bottom-up rather than a top-down basis like we did in the 90s.
Yeah.
If you tell physicians that you can't do a whole-body scan unless you've got this indication, it's amazing the number of that indication that pop up.
Mm.
If instead they feel like they've been represented in a process,
Sure.
then there's some work that says that they'll buy into it and actually go with the flow.
Right.
Especially if they're being incented for it.
Yeah, I agree. Dr. James would agree, right? I think that's a lot of his philosophy. I think I was saying earlier in our meeting that this is not a technology solve. It's a much more. We think actually the service and the kind of organizational change that goes along with this is far bigger than the technology alone. Really, really, truly far bigger, which I think plays to that point. Okay. Any other questions? That's it. So we have 15 minutes left. I'd love to hear how you guys see kind of this shift and how it's impacting kind of things that you're studying, things that you're thinking about in your careers. If you think I'm crazy, if you think this is just a phase that's going to go away, you can tell me.
I've thought about this. I'm sure many in this room have. I think it's important. I mean, clearly we spend a lot more money on health care in the United States and we don't get as good a benefit. The only thing that worries me is if we get completely fixated on cost. There are some, clearly we do too much in health care. There's so much evidence that a lot of the tests we order, the treatments we prescribe, have sometimes are not only not beneficial but also detrimental. But there are, though, some things that work, and there's some things that are beneficial. And my one hope in that in this move to sort of bring these very real cost problems under control is that we don't kind of lose sight of what healthcare is really trying to do, which is, if not make people healthy, at least kind of bring them back from the precipice of being sick.
Yeah, yeah. Do you think, in your view, do you think that's a real risk? Do you think we've gotten the equation wrong, or at real risk for getting it wrong, or?
In some instances, on the other hand, I'm actually a tremendous skeptic of a lot of what we do in medicine. I have medical training. One of my biggest, frustrations when I was doing some amount of clinical practice was how undata driven it was. People were deciding to do things based on hunch, and especially when that hunch was financially rewarding to them. So it would be nice to dissociate the sort of financial reward from people acting on hunches. I think we need to do a lot better job in using data to see what really does and doesn't work in healthcare. But again, just at the end of the day, I hope it's not completely dollar driven.
Yeah, yeah. From a personal perspective, I hope so too. But, yeah.
Well, to take care of that situation, some of the models we created 10 or 15 years ago, we looked at because of the fraud and abuse laws. If a certain percentage of patients would typically get some kind of intervention, we might have a collar around it. So if people tried to go below that, then that could create a fraud and abuse issue. I agree with Dr. Hirsch. There doesn't seem to be anything built in these. There's an exception for fraud and abuse for certain aspects of these ACOs. So I think that is a risk. And then on the other side, I'd be interested in your answer to this question that I haven't been able to answer. One pediatrician from Atlanta once at an AMA conference stood up and said, well, accountable for what? She said, I have patients who eat 3 Big Macs a day. How can I possibly, I can tell them not to eat Big Macs. If I ever saw their parents, I could tell them. But that's another concern that some of the clinicians, I think, right for the ACO have in these models.
Yeah, and I think that's the counter argument that I think is the scariest. I mean, Clayton Christensen, if you guys follow him out of Harvard, if you saw his article in the Wall Street Journal where he was basically saying this is all wrong, this isn't going to work in the end of the day, and it was basically because it comes down to, his basic thing was it comes down to patient behavior, and we're not really doing enough to change those behaviors, and I think there's a lot of validity in that. I do, however, think that's why we put it front and center in some of the needs and what that organizations will need to evolve over time. I don't know. I mean, I was with a doctor a little while ago. He says, my patients have a right to kill themselves. Yeah. So,
I mean, I think I'm hopeful because while anything can be taken to abuse, I think that having a more data and analytic-driven approach allows us to change it to a focus on value, and maybe that value needs to be stratified and grouped according to particular patients and particular situations. If somebody's going to eat 3 Big Macs a day and you can't convince them otherwise, then that becomes a certain patient cohort, and some groups may be better at dealing with that patient cohort than other, and therefore creating more value for the money for the healthcare dollars for those particular people. Now, obviously, it's never going to be as good as if they would stop eating those Big Macs, but it still allows us to ask those questions and focus on the value that can be created. Also, it may. This is also prime for the sort of slippery slope. But if people are going to smoke or eat too many Big Macs, their personal responsibility and their health care costs might have to be higher.
Yeah.
If you insist on behaving in certain ways, the society isn't going to subsidize your risk as much as somebody who doesn't do those things.
I agree. Did you guys read the articles in Health Affairs around patient engagement? And there's a local group called Insignia. They do the PAM scores. I think there's some interesting work happening in that space. I thought that was quite good. Yeah.
I think your remarks were excellent, right on. But one thing that you could maybe do for part of the group is relate this to what might be employment opportunities for certificate and master's students. So I mean, I think that that's on the minds of many people. Those of us that are hoping to teach, it's sort of less on their mind, but the vast majority of us are, or would be looking for a job. And it seems like there's a lot of opportunities. And could you give people an idea of where that you might see them?
Yeah, good question. So a couple of things. One is, so if we kind of go back to the GE businesses that are focusing on this issue, we have 3 tracks to the kind of solutions we're developing. One is software development, so we're looking at things like care management, population health systems. The second one is around analytics. So we have teams of clinical informaticists that work with essentially technology development people and customers to try and find, what are those high-value questions that we're trying to solve for our customers, and how do we ensure that we, answer them in the right way, and that we can actually productize that to make money. And then a third element of our team, which is not really thought of much at GE, but is our consulting team. I have 3 doctors in my staff. I have many, even more nurses in my staff. I have a lot of people who have spent time as data analysts, either in health systems or in other vendors. And essentially, what we're looking to do is we're trying to provide a value proposition to healthcare organizations that say, we're going to help you along this journey from volume to value, and we're going to help you kind of talk about some of those outcomes I showed on that page, and we're going to bring some right domain expertise to the table. We're going to bring some right technology to the table. And oh, by the way, we know you're going to have stuff already that we want to leverage, like your Epic EMR system or your data warehouse that you spent 10 years developing. And so, we're really looking at people who are, I call it multilingual, people who can work across multiple systems. I mean, it's amazing. I don't know how many IT systems OHSU have it, but I'm sure it's in the hundreds, right? And that's the environment which a solutions provider needs to operate. So, just to summarize, clinical informatics people who may have a clinical background themselves, whether it's an MD, RN. We like people who are problem solvers. That's kind of something we're really looking to interview for. So we're people who can solve problems with a customer, and we want to be able to recognize value in the way we price our solutions to our customers for that. So you can do that in either a product development kind of mindset or in a solution delivery kind of mindset. So hopefully that answers the question. It's a great question. We've got 5 minutes left if there's anything else. There were a few hands in the back. I'm not sure if I didn't get to, but yeah.
So we've talked a lot about the shift in the industry, and we touched a little bit about shifts in culture. Have you seen much research or aware of much? There are cultural shifts that happen with things, like seatbelts, for instance. It was a time when nobody used seatbelts, and now, lots of things happen. Laws change, rates change for insurance, things like that. Are you seeing any threads of change in the culture that you find encouraging?
Around some of those bigger topics we were discussing around patient engagement and those kind of things? To be frank, I'm disappointed on how little I see there. In the market research that we did around really changing patient behaviors, and we touched a couple hundred organizations, it was actually more saddening than it was optimistic, to be frank. We had people come to us in focus groups and in interviews and proclaiming to be patient engagement leaders. And when we asked them for evidence of what that meant, they showed us a web page where patients could schedule or view a lab result. Or the firm, they may have gotten an appointments reminders kind of thing out to people. So without being maybe too negative in that space, I feel like that's an area of tremendous. It's ripe for a lot more effort. Not to say there aren't pockets of good things that people are doing. That MedStar person I quoted in the beginning, we're looking at ways that They have a group of 600 high-risk elderly population that they're trying to manage in a virtual care model and really try and get out to their homes and connect it with device data and find totally different care models on how to engage those patients. I mean, that stuff is fantastic, but it feels kind of subscale right now, those projects. And so I don't quite understand how they start to touch the masses. That's where I kind of get worried about it. Yep.
Where do you think things like meaningful use fit into this picture? There is some pushback from Congress around continuing to fund meaningful use.
It's more my personal commentary rather than a real informed commentary, because it's not my area of expertise. I see it as more like they've done a good job of kind of getting the table stakes set. I mean, I think the EHR adoption is an incredibly important enabler for the system, and I want to make sure we continue to push that needle. When I read like the RAND study and other things about the ROI on some of these EHR systems, it's a bit scary. But I don't know. I kind of feel like we didn't ask the airline industry what the ROI was on kind of automating some of their systems, or maybe they do themselves. But I just think there's basic things that we just have to say as an industry we want, and we'll pay for it. And let's optimize it. Let's be smart about how we incentivize it. From a again, I take my GE hat off, even though this is being recorded. Having traveled the world and worked in multiple countries, I'm amazed at how much healthcare IT spend in the U.S. is compared to abroad. I can't understand, whether it's our firm or other firms, how we can spend, why we talk about hundreds of millions of spend around, say, an EHR system here, when fairly similar capability and technology is being sold for 1/10 the price in other countries. So something's happened around the incentives and other things where I feel like that we've got that wrong. So that's off the record, though. I agree.
To attach, to take vessels that come in the door and attach billing codes to them.
Yeah.
I mean, that's more or less what they're built for. They're not necessarily built to improve care, improve quality, and that's why we're in this transition. I mean, so it's like you said, it's kind of hard to measure the ROI yet, because we're still in the spending stage, right? We haven't been able to get to ROI, and the system is still in transition.
True. But man, if they built their business cases on better precision and accuracy of coding to optimize billing and those things, I mean the shift that we're underway, if this takes root like it will come back and bite them. I think.
Flash. It's kind of been brewing since February. All these people who have EHRs now are saying, this is crap software, or this isn't doing what I need, or it doesn't do everything I need, and they're looking for ways to change and get rid of what they've got already after a year.
Yeah. Yeah.
So maybe as an economist you can appreciate, or maybe you agree or disagree, but I think part of the problem, in general, I'm a supporter of free market solutions. I actually think markets work great for the airlines. In fact, the airlines get into trouble when they move away from that. But having Delta competing with United, the problem in healthcare is that the market, in my view, really isn't free in so many ways. When we get sick, we don't go shopping. Just a couple weeks ago, I was driving down to Corvallis, my daughter graduating college, and there's a billboard advertising $485 MRIs, and clearly aimed at people who have no health insurance. But then I was thinking, I'm fortunate enough, I work at OHSU, I have health insurance. If I needed an MRI, would I choose that one because I knew it was cheaper? And of course not. First of all, not only do I have insurance, but also I'd also be wondering in the back of my mind, what's the quality of this? but free markets work when people have access to information, and in healthcare, we not only don't have that, but often just can't have it because we can only know so much. And I think part of our problem in the U.S. is we try to impose a free market solution on healthcare when it's questionable whether it's really going to work. I mean, I think markets can do some things in some areas, maybe around health IT, but the fundamental decision to spend money on medicine is, it's difficult to drive that purely as a financial transaction. As an economist, maybe you agree or disagree with that.
I tend to agree. I mean, especially having lived abroad, 9 years in Europe, 6 in France, 2 in the UK. So I have personal experiences that kind of back that up. But those are my personal views. So I know, but we'll see how it plays out in the U.S. I think we got a long road ahead of us. And one thing I do love some of the innovation that's happening in America, and I think we do have a system which kind of helps some of that innovation really take root. Not so much on the cheap MRIs, but I was with a colleague the other day, and he had whole family had strep throat, and he basically went to CVS and these kind of minute clinics or whatever they're called, and he was quite happy with it, with the care. It was instant. He walked in, etc. And I think if anything, that kind of change at least disrupts the system, right? And I think the U.S. I think we're good at that, right? So.
I think there are some fairly powerful lobbies in the United States that are very upset about the, quote, doc-in-the-box practices.
Oh, for sure. Definitely. It's not easy. So, but we're straying beyond my expertise. Yeah. So I think we've come up time.
Yeah.
I really thank everybody. Just one note, you have my name, I think, in the invite, etc. I'm on LinkedIn. If you want to reach out to me, don't hesitate. It's a small world in healthcare, especially when you go healthcare, informatics, and other things. So, and I'm only up the street to Seattle. So, thank you.